The appendage is categorized into many types by many authors. In the slide which is being seen now, one finds the Wang's classification. So in the Wang's classification, you have the cactus variety, the chicken wing variety, the windsock variety, and a cauliflower type. So these four are the different types as classified by Wang, and this is probably a simple one to follow. These are the chamber models and the wall models to tell us the characteristic of these four types. If you look at the Beutler-Lowry naming system, he has 8 different types: a hook, a seahorse, a finger with knob, a wing, a spiral, a flame, and an arrowhead. Even more complex, extensive varieties of classifications are available, but I would rather prefer a very simple 4-type Wang's for personal reason. The left lateral ridge. This is sometimes called a Coumadin ridge or a Warfarin ridge, which is seen as the Q-tip sign by the anesthetist on TEE. And this was first described by Keith in 1907. And this is what it is. This is the ridge between the left-sided pulmonary vein orifices and the base of the left atrial appendage. Sometimes you see this as a prominent ridge when you're coming off after MVR and the anesthetist asks you, what is this? Is it a clot? And because many anesthetists asked, is it a clot? People call it a Coumadin ridge or a Warfarin ridge, but we could probably call it a Keith's ridge or a left lateral ridge. On the outside of this ridge, one finds the oblique vein of Marshall. The mitral isthmus is what leads to the mitral valve, and in that region you find some of the veins which open directly, the vena cordis minime there, and these pits are called the foramina lanelong. The pulmonary veins which drain into the LA, classical arrangement is 4 orifices, upper and lower of right and left, which is what happens in about 3/4 of the cases. In 31% of these cases, there might be a small or a short vestibule or a funnel-like common vein, and then it enters on the right and the left side. Sometimes you see 5 venous orifices, like in the specimen photograph which we saw earlier. That's found in about 17%, and in about 9%, they had a common vein on one of the sides. So this is how this happens. The radiofrequency ablators concentrate on isolating the pulmonary veins during their ablating sessions. This is because of the presence of these myocardial sleeves. These are muscles which, again, was described by Keith and Flack, which go into the pulmonary veins, and they may have electrically unstable areas which can trigger off atrial fibrillation. So one needs to be mindful of that when you are ablating them with radiofrequency ablation. These muscle strands are mainly circular and with some interdigitating longitudinally and obliquely oriented muscle bundles.